Good evening, everyone. I am Dr. Rajan, working as a senior veterinary consultant at Dr. Agarwal's Eye Hospital, Tambaram. It gives me immense pleasure in welcoming you all to the Flavor of the Month CME Series, OCT Angiography in Diabetic Retinopathy, Basics and Advances. And I thank Dr. and Professor Amar sir, Dr. Srinivas Rao sir, Dr. Ashvin sir, Dr. Preethi, and the entire clinical board to moderate this session. And it gives me immense pleasure and happiness introducing the speaker for today, Dr. Sunil Ganekal, who has done his VR fellowship from Shankar Nethralaya and is currently is the clinical director at Davangere Nethralaya unit of Agarwal's Eye Hospital. And when Sir was doing his VR fellowship, I was doing my PG in Shankar Nethralaya, and he has done his VR fellowship and ocular oncology fellowship from New York Eye and Infirmary. He's a research associate in Mayo Clinic, and he's the past chairman and scientific committee of Karnataka Ophthalmic Society. He has been published more than 50 publications, and he's a reviewer for many world-renowned journals. We welcome you, sir. Dr. Amit Basia, as another panelist, has done his MBBS from Pune and a retinal fellowship from Shankar Nethralaya. He's a senior veterinary consultant at Chennai Center of Excellence, Dr. Agarwal's Eye Hospital. I welcome you, sir, for this webinar. I hand over to Dr. Sunil Ganekal for the CME Series webinar.
Thanks, Rajan. Thanks for the kind introduction. Let me be talking to you basically regarding the utility of OCTA, that is OCT angiography in diabetic retinopathy. I don't have any financial disclosure regarding this particular talk. Why OCTA? Why one should choose OCTA over other imaging modalities is, one is it's a quick invasive modality. It is quite non-invasive. You don't require any dye for the acquiring the images, and you tend to get a 3D images of the vascular network. Basically, you get the clear depth resolved images of the retina and the choroid. So what is the principle on which this OCTA is basically is we look at something called as a decorrelation signals. Whenever there is a non-static tissue like a blood vessel, the RBCs and other things will be moving in the blood vessels. There will be decorrelation between the clear space and over the RBCs, which gives a signal, which in turn will be created to given images. So static tissue will not have a decorrelation, but a vasculature will have a decorrelation, which has been used in many of the OCTA devices to get an images. Either we use two wavelengths of light, either when we use a spectral domain OCTA, we use 800 nanometer wavelength. When we use a swept source, we use 1050 nanometers. Let me show you a video of the principle of OCTA, how it works. At each B scan position, scan is repeated 4 times. The 4 scans are repeated at each line in an OCT cube. So these are the moving erythrocytes. So when the light passes through this, these 4 images are a motion contrast composite of the erythrocyte is created, and you get a clear-cut image like this, which in turn gives a good NFAS image, and an OCTA cube is generated. So basically, laser light reflectance from the surface of the moving RBCs are used in this OCTA as a principle. So we use something known as amplitude decorrelation. The amplitude varies from one structure to the other structure. When there is an amplitude variation, you tend to get a clear images. The other thing is the phase variance, where variation of phase, when it intercepts with the moving objects, you tend to get an image. These are the principles of the OCTA. As I told before, serial based on the amplitude decorrelation, serial scans are taken. This is an amplitude. You can see clear decorrelation between each of the reflected images, and you get an NFAS image. Why you should have a split spectrum amplitude is, this is a full spectrum amplitude image. You are not able to appreciate much of the structures, but with the split spectrum amplitude, you can clearly see the foveal avascular zone and the vasculature in the retina. So to improve the visualization, we follow what I told, what is known as split spectrum amplitude decorrelation algorithm or volume averaging. These are the 2 methods which we use to reduce the background noise to what we call it as a denoising to get the clear-cut images. Let me show you how you get the cube gives out the layer by layer images, 3D cross-sectional imaging of the fundus, scans layer by layer. First, we'll be scanning the superficial vascular plexus or superficial capillary plexus. So this is a superficial plexus. Then comes the deep plexus. Then the outer retina. The layer of choriocapillaries. And you get a composite colored map also for the analysis also. See, basically superficial, the slabbing, what we call, differs from one octa machine to another octa machine. Typically, superficial vascular plexus starts from ILM up to the 15 micrometer below the IPL, that is inner plexiform layer. The deep vascular plexus starts from the IPL layer and goes up to the outer plexiform layer. So basically, superficial vascular plexus consists of large vasculature, and deep capillary plexus consists of small sized capillaries. So you need to look into both the layers, especially in diabetic retinopathy and especially the deep capillary plexus to know what are the pathological changes which occurs in diabetic retinopathy. Image sequence I showed you already. First, what you get is the superficial vascular plexus, then comes the deep capillary plexus, then the layer of choriocapillaries, then you get the choroidal layer. But one big thing about the octa images is the default setting in each images varies from one machine to another machine. For example, this is a spectralis. See, there is a clear-cut variation between spectralis and an Aventi and with the cirrus. If you compare cirrus and the segmentation slab may differ from one machine to another machine. So the one important thing is whenever using an octa machine, better to have a repeatability in the same machine rather from switching over from one machine to other machine. This is a clear-cut image which shows how each machine will have a segmentation slab which differs from the one another. Usually, all the octa machines, the scan speed ranges from 7,000 to up to 70,000 to 1 lakh. They will have a resolution of around 3 to 5 microns. Scan time is approximately 3 seconds. Here, the like OCT will have an refractive error dioptric adjustment will be there. Retinal scan maximum you can go up to 12 by 12. You can start with 3 by 3, then 6 by 6. You can go up to maximum 12 by 12. If you got an attachment of an anterior segment, also you can get an anterior segment scan from limbus to limbus, which is around 16 to 16 scan. Like autorefractometer or any other measurement, this will have a full auto-aligned machine. It will have a fixator also. There are so many machines in the market, but each one differs from one another with respect to the resolution, the magnification, the scan depth, the algorithm which they tend to use in each of these machines. So I will briefly show you what are the things which happens. When you look at the machine, you should look at whether it is a spectral domain machine or a swept source machine. The next, the algorithms, the various algorithms which have been used. The commonest being the split spectrum algorithm, which I told before. Other algorithms I will be telling you next. A scan speed, I told you already, it starts from 70,000. It can go up to the 1 lakh also. The wavelength, either it range from 800 to 1050 based on these things. Some will have an eye tracking system. Maximum image size, you can clearly see that. Some will have 8 by 8, some will have 12 by 12, some will have 9 by 15. And automatic montaging will be available in some of the machines. You need not manually sit and do a montage, means overlap one image next to the other image to get a panoramic view. The lateral resolution and the axial resolution also varies from one to another. Some machine will have an associated multimodal imaging, the red-free imaging, fundus autofluorescence. So many of these things are varies from machine to machine. Some are FDA approved, some are non-FDA approved. So you will have, I will be, so based on these things, you can choose the machine and the cost also varies. Okay, the cost also varies accordingly. Okay. I told about the algorithms. The commonest algorithm, what we use known as split spectrum amplitude decoloration algorithms. Other algorithms which have been described is something known as the difference analysis angiography, the micro angiographic algorithm. See, these are the machines. Based on the various algorithms, you tend to get these images. Heidelberg will have a different one. The Angioplex will have a different algorithms. So based on this, different machines use the different algorithms to get you clear-cut images. The main problem with any of the octa machines is the artifacts. Some could be related to the projection artifacts, what we call, while imaging, it takes a little bit time. You'll have a loss of signal and you can have an artifacts. Sometimes segmentation errors can occur. Sometimes the vessels itself can bring about the artifacts and you get a duplicated vessels. Alignment errors can occur sometimes, that can cause image processing errors can occur. The motion artifacts, because suppose the patient is a poor cooperative patient, the blink artifacts can occur. stretch artifacts can occur, and image displacement can occur. So many artifacts can be induced in the images, which gives a erroneous readings or the false images, or the images may not be clear. Here is a patient with the motion artifacts. This is how the fixation artifacts, you don't get a clear-cut image. Then there is a projection artifacts. What happens is sometimes the large retinal vessels itself cast a shadow on a deeper layers, and you tend to get a projection artifacts. Most of the machines will have a corrective measures for this artifacts, something known as adaptive slab feature. For example, this is a patient with a PDR with a neovascularization, which is not seen because of the leakage on FFA. But if you look at the octa, the full thickness slab of the retina just shows a neovascularization. But if you scan at the level of the vitreous, you can see only the neovascular network. Rest of the tissues are, the background is merged, it means masked, so that you get a clear-cut image. Other thing is segmentation corrections also possible. Then there is a projection artifacts removal options will be there. For example, this is a patient with a choroidal neovascular network, so clearly seen. Here with the projection artifact, due to projection artifact, this CNVM was not visible, but after the projection artifact removal, you can see a clear-cut neovascular network. So I told about the eye movements also will have a compensator algorithm. So these corrective measures can be applied to most of these artifacts, and you can get a clear-cut image. Why we have to choose an octa over fluorescent angiography is basically for a couple of reasons. As you know, FA is an invasive procedure, dye-based procedure. The resolution is quite low. The FA gives a two-dimensional image. Octa gives a three-dimensional image. FA analyzes only the superficial vascular layers. Octa analyzes both superficial and the deep vascular layers. And the acquisition time is also very less. And you tend to see a leakage in FFA, but sometimes it could be disadvantageous, because the vascular network may not be seen if you see any image with a leakage. So octa has got an advantages over FA in many other things. So why one should use an octa in diabetic retinopathy? Let's come to that point. The one thing is diabetic retinopathy is slowly progressive. It's a long duration course it will have, and a long subclinical period. Most of the patients, our patients who are visiting the eye clinics will be in the pre-diabetic stage. So in the subclinical stage, studies have shown even the octa changes are seen in pre-diabetic stages also. You can pick up the changes in the retina before the diabetic retinopathy changes occurs. So this is a very, very important thing in the subclinical stage. You can pick up the subtle changes. And sometimes the clinical examination underestimates the severity of the diabetic retinopathy. So you move on to the imaging modalities like FFA and octa for these things. The another important thing is almost 40% of the patients with diabetic retinopathy will some form of macular ischemia, which can be easily diagnosed with octa. So as I told, FFA looks into the superficial plexus, and the octa looks into the deep capillary plexus also. And the leakage will sometimes obscures the vision in the image in FFA. So I told there are various image scans. You can get 3x3, 6x6, or a 12x12 scans. This is a panoramic single frame image. We can clearly see up to the retinal periphery with a neovascular network, capillary non-perfusion area. This is a patient with a PDR or a proliferative diabetic retinopathy. It is easy to follow up also. These are patients before the early stages of diabetic retinopathy over a period of 2 years. You can see how it progresses to PDR. So you can easily follow up these patients non-invasively without any dyes. What are the changes you tend to see in diabetic retinopathy in octa? One is capillary abnormalities you will see. The most important thing is foveal avascular zone alterations can be easily picked up. You can quantify the vascular changes like a flow, density, other things and all. You can clearly pick up the neovascularization herein. And most of these octa changes tends to correlate with the visual acuity. So morphological changes in DR, the most common being the microaneurysms, non-perfusions can be seen, the venous beading, and the capillary non-perfusion, the foveal avascular zone erosions. So there are many morphological features which can be picked up in octa. Now coming on to the most important morphological feature and earliest morphological changes which occurs in diabetic retinopathy, which is the microaneurysms. Once you see the microaneurysms in octa, we should look at the depth of the microaneurysm, whether it is superficial or deep. You look at the internal reflectivity in the microaneurysm, the morphology and anatomical location should be looked into this, because the microaneurysms predict the risk of DME, how fast the DME will progress over the next 1 year, and you can assess the treatment response also. Not all microaneurysms are picked up on octa. Sometimes octa can be inferior to FFA, especially in the microaneurysm detection because of the sluggish flow. But one important thing is please look into the microaneurysm reflectivity on the octa, because microaneurysms with high reflectivity are more likely to be detected on octa than those with the low reflectivity. As you know, the internal structure of microaneurysms depends. It could have a lipid content, it could have a layered endothelial cells. So reflectivity of microaneurysms varies. So, and another thing is hyperreflective microaneurysms, if you see on an octa, they show a better response to anti-VEGF and steroids when compared to the hyporeflective or microaneurysms with a sluggish flow. So looking at the reflectivity, you can assess which will have a better response to the anti-VEGF and steroids and which will not. So which is a very, very important thing. The next another important morphological feature is what you tend to see is an IRMA, which needs to be differentiated from a neovascular network. So caliber of these loops are greater than that of the surrounding capillaries. So this is a network of IRMA which you can see. You can confuse this with neovascularization, but the most important thing is these never breaches the interlimiting membrane because they never protrude into the vitreous cavity. They will be on surface with the retina, and they will be most often adjacent to the capillary non-perfusion areas. So the typically, as I told before, they never cross the boundaries of the ILM. They show a heterogeneous behavior. See, one thing is you can closely follow up this IRMA, especially in PDR patients, those who develop post-PRP also. So IRMA may regress, but those tends to be regress earlier where there is a vascular perfusion is there. Where there is a capillary non-perfusion is there, these areas may not regress so early, the post-treatment. There are various subtypes of intraretinal microvascular aneurysms which have been described on octa post-PRP. Some IRMAs may be unchanged. Some may have a tuft regression, what we call. Some may have a reperfusion of the IRMAs. Some may have a mixed tuft and reperfusion. Some may have a worsening, means new appearance of tufts post-PRP. So these are all these changes in IRMA can be analyzed in a post-PRP patient non-invasively. Now coming on to the important neovascularization, that is the morphological change, that is a neovascularization. These epiretinal neovascularization can be easily seen on octa. The most important thing is absence of leakage, which allows us to precisely delineate the neovascular network. As I showed previously, if you look at the slab at the vitreoretinal interface, which allows the better visualization of neovascularization, you can follow up this neovascularization pre and post treatment also. You can clearly see this is a normal full thickness retinal slab. This is NVD which is taken at the level of vitreoretinal interface. See how well you can highlight this in the optic disc neovascularization NVD. This is a pre-treatment, this is a post-treatment. There is a regression of NVD. Similarly, NVE, which has been highlighted at the level of vitreoretinal interface, you can see a clear-cut network of the neovascularization elsewhere. One thing is the FA sometimes carries an advantage over the wide field octa. The wide field octa sometimes may not cover the extreme periphery, which can miss some of the peripheral changes, but ultra wide field FA sometimes can bring about some of the additional peripheral features which are not seen with the wide field octa. So when you see a neovascularization, what to be looked for? One is look at whether it's an active or an inactive, the dimension of the neovascularization, caliber of the vessels, the vessel density in the neovascularization, the perfusion density and the flow area can be picked up on neovascularization. But this is, and the sensitivity is much more higher if it is a treatment naive patient than a treated eyes. So one advantage is octa can detect subtle neovascularization in most of the cases without any dye-based angiography. So you can clearly see the different level of slabs, and you can easily follow up this neovascular network, what happens, the prior treatment, and this is from plexal light image, which shows the neovascular network which have been taken at different slabs. You can clearly see the neovascular network is a patient with a PDR showing a superior temporal neovascular network. On post-treatment with an anti-VEGF, you can see that this has been regressed. This is a beauty. The morphological changes or regression can be seen as early as week to 10 days post anti-VEGF injections, and you can assess the vessel density also in these neovascular fronts post-treatment also. One another important sign which indicates whether the new vessels which you see on octa are active or inactive, what we call epiretinal exuberant vascular proliferation. What is this exuberant vascular proliferation? You can see the arrowheads here. These are the large trunk vessels. These the arrow indicates terminal loop anastomotic vessels. Okay, But if you see this elliptical vessels, what we call EVP, that is exuberant vascular proliferation. What is this? If you see an intense irregular proliferation of small caliber new vessels at the margin of new vessels, if you see an EVP or an exuberant vascular proliferation, it does indicate that neovascularization is quite active and it needs further treatment. So, and another thing is EVP and OCTA correlates with leakage and FFA, which shows that if you see exuberant vascular proliferation, it is an active disease. So this is another stage which shows on a color fundus photograph, you don't see anything, any neovascular network, but you can on an OCTA, wide field OCTA, you can see that neovascularization is still active. And you can assess the flow also in NVD and NVE in these patients. Wide field OCTA, how you can obtain a wide field OCTA is, there are many methods. The conventional OCTA, you can introduce a +20 diopter magnifying lens and get something known as extended field of imaging, but it will have its own drawbacks with this. The ideal technique would be single shot 12 by 12 mm scan rather than a montage or an extended imaging. So but the one problem with placing a 20 diopter lens, for example, you see this is a normal OCTA, this is an extended field OCTA. By placing a 20 diopter lens, you can magnify the image, but the one disadvantage with this thing is it underestimates the vessel density and overestimates sometimes the non-perfusion areas. The montage, of course, it is a time consuming. You have to overlap the images, needs optimal cooperation and avoid misalignment of the vessels. You need to align them properly, and it's a time consuming procedure. The best would be to get a single shot image. Once you get an en-face image like this, it undergoes certain processing of the image to get a whatever the required thing is there. What we call it as an image denoising. So once you do the image denoising, you get a foveal avascular zone acircularity. Then you convert this into by black and white image, what we know as binarization. Then we do something known as skeletonization to track the individual vessels, which gives an idea of the vessel length, vessel density, and the intercapillary areas can be picked up. And the another thing is you can pick up the what is known as fractal dimension. What is this fractal dimension is the tortuosity of the vessels can be picked up on an OCTA apart from vessel density and the perfusion density. So as I told, each image undergoes a binarization and a skeletonization to pick up the vessel density and the perfusion density. Various quantitative metrics can be assessed with the OCTA. Let me show you, this is a very, very important slide. Some quantify perfusion, some quantify the non-perfusion. In the quantification perfuse, you can see the perfusion density, vessel density, flow index. In the vascular pattern, you look at the tortuosity of the vessels, vessel diameter the index. Then in the FSZ area, you look at the area, the perimeter of the FSZ, acircularity means how much of the FSZ is deviated from the circular network. Then you tend to look at the intercapillary area. Then there is something called as geometric perfusion deficit. There are various quantitative matrices you can assess with the OCTA, and some tend to correlate with the severity of the diabetic retinopathy also. But not all these indices are repeatable consistently. The most often what we know as skeletal density, the vessel density, the fractal dimension, and the vessel diameter index. These are some of the parameters which can be easily repeated in an OCTA. So vessel density basically indicates the proportion of the blood vessel area which is available to a particular amount of total measured area. The vascular length or a skeleton density, basically as I told before, it can be picked up from a skeletonized images. You can calculate something known as the vessel diameter index based on the vessel diameter and the vascular length dimension. The fractal dimension, what is it? Basically, I told it picks up the vascular branching network. How much is the branching pattern is there? Then what we call it as vascular tortuosity index. How much is the vessels are tortuous and other things. And similarly, another indices which can be picked up is the vascular complexity index. Most of these are auto-generated. Somewhere you have to do a manual software assisted things to pick up this quantitative matrices. Why vessel density is important? This slide clearly shows that as you move from normal to PDR, there is a decrease in vessel density, so that it tends to correlate with the severity of the diabetic retinopathy. In a perfusion map, you can see either the bright red images or a dark blue colored images. The bright red images basically indicates the perfusion density greater than 50%. Blue indicates non-perfused vessels. So you can detect a perfusion density and you can assess the severity of retinopathy. And the OCTA can clearly detect as the severity of diabetic retinopathy increases, the capillary non-perfusion also increases over a period of time. Now coming on to the most important thing, the diabetic macular edema, how the Octa helps in diabetic macular edema. All we know, diabetic macular edema, basically, I will not be talking about tractional DME here. I will be talking about only edematous DME and the ischemic DME. The most important thing is do not provide leakage information, unlike FFA. The most problematic thing of Octa in DME is segmentation errors. You tend to have fluid in DME. This fluid does not allow us to segment the layers automatically. It will have a segmentation errors because of the irregular layers. Even the flow patterns will be altered, and the Octa changes tends to correlate with the extent of capillary non-perfusion. Is a patient with an DMA where Octa has been done, because see, you can see the edematous tissue, it is difficult to segment sometimes, but sometimes you can see an grayish area in Octa imaging, which tends to correlate with the area of the fluid on a B scan or a regular OCT. So there will be correlation between the OCT and the Octa. Obviously, and if you look at the ischemic maculopathy and if you're looking at an FAZ, Octa scores over the FA, because FA, because of the leakage and other things, the foveal avascular zone will be not much well delineated in a FA compared to the Octa. I was talking to you about the vascular network, but I told diabetes affects both superficial vascular network and the deep vascular network. But one need to look at the more into the deep capillary plexus than into the more into the superficial plexus. Why? Because the ischemic damage insults more of the deep capillary plexus in diabetic retinopathy than the superficial plexus. The deep capillary plexus ischemia directly correlates with the pathogenesis of DME. If you see a fluid in the superficial capillary plexus, if the deep capillary plexus is not affected, that fluid gets absorbed much faster. It shows that the pathology is more confined to the deep capillary plexus than the superficial capillary plexus. Another important thing I told about the deep capillary plexus is deep capillary plexus consists of the small caliber vessels when compared to the superficial capillary plexus, which have a larger caliber vessels. Smaller the caliber vessels, the chances of leukostasis, the stagnation, the occlusion, all these chances are more in deep capillary plexus. So you need to look at the deep capillary plexus might be critical for in assessing the treatment response to anti-VEGF, because these small caliber vessels gets affected in diabetic retinopathy much more severely than the superficial capillary plexus. So early involvement of deep capillary plexus is supported by enlargement of FAZ. So you need to look at the deep capillary plexus very clearly. I told about the segmentation errors because it's a time consuming, and sometimes what happens in DME is, if you see a cystic spaces, the cyst tends to displace the vascular network. So it gives a false erroneous thing saying that these are capillary non-perfusion areas. Another important thing is, if you see a short axial length, you tend to see a larger FAZ areas. If you see a long axial length, you tend to see a smaller areas. So you need to apply a correction formula in a long and short axial length. If you look at the FAZ measurements, what we need to look at is the size of the foveal avascular zone, the contour, whether is in regular or irregular, area can be measured, even the perimeter can be assessed. The other thing is the axis ratio. The FAZ is not uniformly circular, it will have a major axis and the minor axis. So axis ratio can be picked up. Acircularity, which is how much of the FAZ is irregular compared to the normal. So this is a very, very important index. The other thing is the vascular density within the 300 microns surrounding the FAZ area can be picked up. One more thing is, unlike FAZ area and other things, acircularity index does not require axial length corrections. So we need to look at AI, that is acircularity index is much more sensitive in assessing the progression of DME than foveal avascular zone area as well as the perimeter. You can clearly follow up these patients. This is a normal eye, this is a diabetic eye, this is an advanced eye. You can look at the area of foveal avascular zone as the diabetic retinopathy progresses. As I told, you can assess the area, the perimeter. This is the major axis of the FAZ. This is the minor axis of the FAZ. And if you compare A1 and A2, you tend to get the acircularity. So you can assess many of these parameters accordingly. In an ischemic maculopathy, you tend to see an foveal avascular zone enlargement, which basically indicates macular ischemia. These changes can be seen in a normal diabetic patients without retinopathy also. The FAZ enlargement can be seen in both superficial capillary plexus and deep capillary plexus, but one need to look more clearly into deep capillary plexus than the superficial capillary plexus. As I told before, FAZ enlargement can be seen much better on an octa than a fluorescein angiography. But FAZ measurement has got its own limitation. For example, FAZ measurements can vary from one person to another person. The normal range can vary from anywhere from 0.071 to 0.527. And sometimes FAZ may be absent in some of the diabetics. And some part of the superficial capillary plexus in segmentation slabs can involve the part of the deep capillary plexus. So it gives an erroneous readings of the foveal avascular zone. And sometimes the manufacturer gives a default settings which may have overlapping segments. So FAZ measurements can be variable, but as I told before, even though there is an inter-device variability, if you keep on measuring with the same machine, you tend to get a better readings. Sometimes the readings can be erroneous due to the wrong location of the FAZ, the vessel casting a shadow on this, and parafoveal non-perfusion areas may be there, which gives an erroneous feeling of an enlarged foveal avascular zone. Sometimes a media opacity which casting a shadow on the foveal avascular zone prevents the taking a proper readings of the foveal avascular zone. And of course, sometimes there could be difference between, as I told, machines you can do a manual segmentation and an automated segmentation. Both can give a different readings in a foveal avascular zone measurements. Sometimes what happens, some studies have shown, don't take superficial capillary plexus and deep capillary plexus separately. You go for one thing known as summated plexus. Combined both superficial capillary plexus and deep capillary plexus, you can combine together, you can take a foveal avascular zone measurements. Those tends to correlate better with the severity of diabetic retinopathy than with the individual segmented slabs. As I told, it can vary from thin. If somebody has got a thin fovea and thick fovea, you can see this is a patient with a central macular thickness of 221 microns. This is with a 275 microns. See how the measurements varies. Even the circularity, axis ratio, solidity, roundness, all these varies. So one should be very careful in assessment and judging and analyzing the patients. So you need to keep a watch on these erroneous factors. I told acircularity index is the most sensitive index which keeps on progressing. You can see early DME, advanced DME, and severe DME. It progresses or keeps on increasing as the severity of DME increases. Even the vessel density, as the DME progresses from early DME to advanced and severe DME, the vessel density in the deep capillary plexus tends to drop more than the superficial capillary plexus. So one need to look into the deep capillary plexus much more thoroughly in octa patients when compared to the superficial capillary plexus. As we know, the OCT images gives us some important biomarkers which is known as DRIL, that is a distorted retinal inner layers. These distorted retinal inner layers, if you see on an OCT, which usually tends to correlate with the non-perfusion areas or capillary non-perfusion areas in a patients with an octa. So there is a significant correlation between the non-perfusion and the presence of a DRIL. Even as we know, the outer plexiform layer is the most important outer retinal layer which is required for the visual function. If you see a distorted outer plexiform layer on an OCT, which tends to correlate with the non-perfusion areas on an octa. Another important geometry, the one thing is you can measure the intercapillary non-perfusion areas and quantify something known as geometric perfusion deficit, which also progresses as the severity of the diabetic retinopathy increases. The one important thing which has been described in octa, which is known as SSPIM. What is this? This is a suspended scatter particle in motion. What does it mean and what does it indicate? These are extravascular motion signals seen both basically in NFAS octa images. Those with SSPIM, if you see them, they show a significantly large non-perfused areas in diabetic retinopathy. And if you see SSPIM, they tend to have a lower treatment response in diabetic retinopathy when compared to the normal patients. Sometimes if you see SSPIM areas, these areas, if you closely follow them over a period of time, these areas, they in turn turn into the odd exudate areas. And these may cause the concern and cause a treatment resistance in these patients. So if you see a suspended scattered particle in motion is an important diabetic, the biomarker in octa in treatment response to the DME. So here is a patient with the scattering particle, that is SSPIM, what I told, and after the manual correction, you don't see much of the SSPIM. It can be corrected. Another important thing is why I told about the inter-device variability is You can see here, this is an area of foveal avascular zone. Look at the reflectivity in a plexus light machine. Look at the reflectivity in an angio view machine. So each one will have a different reflectivity because the algorithm which has been used for different machine is different. For example, the plexus light may use a split spectrum amplitude decorrelation. Angio view may use an OMAG algorithm. So one should be very careful with the inter-device variability. So another entity is we tend to look at the chorea capillaris also in a diabetic retinopathy, which we tend to call it as diabetic choroidopathy. Basically, you tend to see the flow void areas. The chorea capillaris, there will be flow will be absent in most of the diabetic retinopathy. These flow voids in chorea capillaris also tends to increase as the severity of the diabetic retinopathy increases. And you can look at the optic nerve also in diabetic retinopathy changes. In diabetic retinopathy patients, the peripapillary vessel density tends to be lower, and which in turn correlates with the NVD. So more the peripapillary vessel density dropout, the higher risk of development of neovascularization on the surface of the disc. So reduction of the optic nerve vessel density tends to correlate with the worsening of levels of visual acuity as well as the development of neovascularization on the disc. Another important use of Octa is monitoring the treatment response. Let me show you some of the examples. This is the pre-treatment neovascular network. This is the post-treatment. You can clearly see how the caliber of the vessels has reduced and the network has reduced. So you can easily, non-invasively, you can easily follow up these patients. Here, you can see that color photograph, fundus photograph. You can clearly label this patient as a well-lasered diabetic patient without any active neovascularization. But you do a wide field Octa, you can see a persistent neovascularization with a capillary non-perfusion area. This patient still needs an additional treatment. So you can't say that it's an inactive disease, still it's an active disease. The post-PRP also, you can follow up the patient. You can't say, you can see that the neovascular network, there is a decrease in caliber. So post-PRP, persistent neovascularization can be easily followed up. See, this is a neovascularization network you've seen. This is a regressing neovascularization. And this can be proved on FFA also in the same patient. There is no leakage. So Octa changes invariably well correlates with the FFA. So you need not do FFA in all these patients. Another important advantages in some of the machines is change analysis. The patient keeps on coming up for follow-up on each visit. You can follow up the vessel density. You can follow up the FAZ area, perimeter, circularity on each image and each visit. And it tends to give a correlation with the previous visit, whether it got enlarged, whether there's a drop in vessel density, whether there's a change in perfusion density, whether change in the FAZ area and circularity. All these change analysis gives an summated analysis of a patient, which helps you to follow up the patient in a subsequent visit, and you can take a decision accordingly. You can see the clear-cut treatment response. You can see the cystoid spaces. This is the pre-treatment and the post-treatment. We tend to correlate, so you can see the treatment response to anti-VEGF. Suppose a patient comes with an anti-VEGF non-responder. Suppose there is a patient with a DME, there is no optimal response or a reduced response to anti-VEGF. What could be the causes, or which are the cases which shows a suboptimal response? If you see a loss of integrity in the deep capillary plexus, as I told before, if you see an FAZ enlargement, if you see a higher number of microaneurysms, if you see a lower vessel density, especially in the deep capillary plexus, if you see a lower parafoveal vessel density in the superior capillary plexus, these are the 4 or 5 parameters which shows that patient may have a suboptimal or a non-responsive to anti-VEGF. So you need to monitor all these factors. If you see them pre-treatment, you can tell the patient these may not respond optimally to anti-VEGF treatment. So similarly, the treatment response can be monitored in this patient. Similarly, DEX implant patients, what happens if you treat them with DME patient? What are the changes you tend to see pre-treatment and post-treatment? You can see a significantly reduced vascular perfusion, decrease in the vessel density, but there won't be any non-significant enlargement of the foveal avascular zone, and there will be decrease in the caliber of the vessels, especially in the deep capillary plexus, post-dexamethasone implant in a DME patient. Similarly, nowadays we are resorting to the yellow lasers or macular subthreshold lasers. Initially, you may not see much response to the macular subthreshold changes on Octa, but over a period of 6 months, there will be decrease in FAZ in deep capillary plexus, but there won't be any significant difference in vessel density, unlike intravitreal injections. I told about the suspended scatter particle in motion. These are the poor prognostic factors, but you need to look at which location or which depth these suspended scatter particles motions are there. If they are located in the inner nuclear layers, there won't be much response or much change in the treatment response. But if you tend to see in the outer nuclear layer, probably these tend to respond much better to steroids compared to the anti-VEGF. So you need not stick to the anti-VEGF, shift over to the steroids. What are the OCT biomarkers which says that patient is having worsening diabetic? One I told, enlarged FZ, decreased foveal avascular zone circularity, lower vessel density, increased vessel diameter index, decreased fractal dimension, that is tortuosity. These are some of the changes which indicates that there is a worsening of diabetic retinopathy, and these are more predictive in the deep capillary plexus than in the superficial capillary plexus. So the OCTA biomarkers, they tend to correlate with the vision as well as with the retinal thickness, as well as if you look at some of the superficial capillary plexus changes over a period of 1 year, they tend to correlate with the retinal sensitivity changes on a microperimetry. So most of the OCTA biometers can be combined and compared with the other multimodal images. For the completion sake, if you have got an anterior segment attachment, you can trace and detect the NVI in iris using an anterior segment CT. You can see here the before injection and the after injection, the regression of NVI. This is 1 week post injection. You can see the flow signals also. This is a pre-treatment flow signals, these red dots, which tends to be decreased post anti-VEGF injections. So anterior segment OCTA will allow us to monitor even the neovascularization of the iris. But OCTA has got certain limitations, as I told before. This is an evolving technology. The leakage cannot be picked up. Image acquisition area is small, unlike ultra wide field OCTA. Sometimes there could be artifacts. The segmentation problem can be there. Sometimes what happens is you may not be able to find difficulty in identifying which is a pathological vessel and which is a normal vessels. And you can miss some of the microaneurysms if there is a sluggish flow. But how the OCTA has changed our practices, the most important thing is it can non-invasively detect most of the ischemic maculopathy. It helps to differentiate IRMA from the neovascularization. It helps us to identify who are the non-responder to anti-VEGF, which are the patients which require steroids. So caution must be exercised because there are a lot of limitations. So in conclusion, I would like to say is that OCTA can detect both functional and structural changes. But one important and the most important thing is there is an inter-device variability. So you need to repeat with the same machine to get the reliable results. It can pick up retinopathy changes in the subclinical stage itself. You can assess the pathophysiology, assess the progression of retinopathy and the treatment response. Biomarkers of the OCTA helps in assessing the therapeutic response, can substitute FA in most of the cases, and it complements many other imaging modalities. I would still advise one should stick to the multimodal imaging, but it can definitely replace FA in many of these things, especially in ischemic maculopathy and in detection of neovascularization, and thus this helps in managing the diabetic retinopathy in a better way. Thank you. Thank you for your patient hearing. If you have any questions, I'll be more than happy to take it.
Dr. Sunil, it's a very nice and very elaborate presentation of OCTA. Very nice presentation. One question to you. You said that in the steroid, you have to look at the outer nuclear layer.
No, that is one of the markers. Unlike hyperreflective foci, what you tend to see in OCT, it's not a suspended scatter particle motions is not the only indicator to switch over to steroids. It is one of the biomarkers. If you see, I would rather prefer a steroids over anti-VEGF. It doesn't mean you should not give anti-VEGF.
Yeah, right.
Sir, you said about the pre-diabetic retinopathy. It's like, is it mandatory for all the diabetic patients? Opt-out should be done at some point of time. You advise, sir.
See, the one thing is in a subclinical stage, many of the patients may not accept to undergo an OCTA, but the
Yes, sir.
literature does show that the pre-diabetic stage, many of the changes have been picked up, like the vessel density. If you compare it with the normal patients, there is a reduction in vessel density and the foveal avascular zone alterations. Many of things have been picked up pre-clinically also, because most often, if you see, the diabetic patients tends to have a long subclinical course. Once the startment of a diabetic and development of clinically detectable diabetic retinopathy, there is a long gap. This gap is the thing. If you can pick up most of the things, you can tell the patient saying that you are higher risk of developing diabetic retinopathy compared to the other patients.
Performing grid laser or in modified grid laser, will FFA will be more better than an Octa, sir?
See, we are more shifting over from hardly I do any grid or a modified grid laser in the anti-VEGF era. See, the only thing is resistant cases only you tend to do an FFA to pick up why something is resistant to anti-VEGF. Then, unless it is a non-center involving DME, probably you tend to do a laser. Otherwise, for all center involving DME, most often the OCT is good enough tool to give the injections rather than relying more on a FFA.
Nowadays, we are not using modified grid pattern. Like it is very, very limited.
Yeah, that's what hardly we
In
only in
anti-VEGF
resistant cases.
era, we have stopped using actually.
Yeah, correct. But some cases, refractory cases, definitely laser has got a
Yes.
role, and especially yellow laser. If you got an access to yellow laser, that's the best thing.
But even in those refractory cases, I feel that post FFA, if you do a focal laser, that gives a very good result post focal laser. Like modified grid has a very, very
Rather,
limited.
I told, I think previous also when last webinar or a CME thing which you heard when Dr. Manoj Khatri presented, there is an entity which has been described known as telcaps, the retinal telangiectatic things. These are macroaneurysms. These are not microaneurysms.
Microaneurysms.
If you see, these can be easily picked up on an OCT and FFA. These are the cases the focal laser definitely helps.
Yes.
Any
Questions? Anything they want to?
if there is a presence of hard exudates, will Octa be hard exudates at the macular? Will Octa will be a better option or?
Hard exudates per se may have a casting shadow and segmentation is also difficult sometimes. But most of the conventional structural OCT is more than enough than an Octa in cases of hard exudate. Basically, Octa, I rely more on the ischemic changes, vascular changes, neovascularization, any flow-related changes and the other things, density changes. The Octa carries an advantage over the OCT.
Yes, the cases where we need to do repeated evaluation to find out
Follow-up
whether our
patients. And the
treatment
best
is
part is that,
working.
as I told, change analysis. You can seriously
Yes.
follow up these patients and tell that one of the things that we on a sequential follow-up, whether there is a regressing or improvement is there or not, and those things can be picked up.
Correct. Like in cases of NVI, we
Yeah,
need to
definitely.
evaluate anterior as well as posterior. So post PRP, whether any ischemic sector is remaining, which needs additional
But
treatment.
it's a more of a I don't do much for the anterior segment to Octa, but posterior we definitely use. But subtle NVIs, if you got an access to anterior segment Octa, it can be picked up like iris fluorescent angiography way they do. Even the Octa non-invisively can pick up NVI.
But I have
The
never done
peripheral
like for anterior segment Octa, like
You need an
the,
attachment for that, the anterior segment
yes,
attachment.
yes.
It was an excellent presentation, sir. In the images were mind blowing, actually.
Thank you, Rajan. Thank you.
Yeah,
Yeah, you have
that's
included like each and every minute details of
yeah.
Okta,
That was
whatever it is
that's like reading a book. It was
known
like
at
reading a book,
present, you have
actually.
included it. It's a very nice presentation, especially those
Thank you,
videos and all those things.
Yeah.
I'd like
Rajan.
to thank Dr. Ashwin Agarwal, who is the chairperson for our editorial board, and Dr. Preethi, who is the heading the scientific sessions, and for inviting us for this education committee flavor of the month series. So I would like to thank Dr. Preethi, Dr. Ashwin Agarwal, and all other team members who are involved in conducting such beautiful sessions and knowledgeable sessions, so that everybody will get benefited. And this is from my side. I'll hand over to Dr. Rajan for further.
Yeah. It is very nice for having Dr. Sunil sir and Dr. Amit sir in this CME. Thank you once again, and good night, sir.
I thank once again the clinical board for the opportunity. Thank you,
Yes,
one
sir.
and all. Good evening
Yes,
and
sir.
bye for the day. Thank you.
Yeah, yeah. Thanks, sir.